Hi, my name is Tarek, and today we're going to discuss the physiology of the synapses with clinical correlates, and we're going to do a quick channelopathy review. So we're going to discuss the basics, but you likely already know it to an extent. The presynaptic cell is separated from a postsynaptic cell. So you have your presynaptic cell, your synaptic cleft, which is this empty space, and then a postsynaptic cell. All right. So the presynaptic cell is separated from the postsynaptic cell by free space, and neurotransmitters are going to be released by exocytosis into this free space and then bind on receptors. So you'll have these vesicles, they'll contain neurotransmitters, and what will happen is that the vesicles will be sort of brought in by some proteins that we'll talk about later, and those proteins will fuse the vesicles with the presynaptic membrane, and then the neurotransmitters will sort of get released in. So what's happening is this vesicle membrane sort of fuses with the presynaptic cell membrane. So these membranes become continuous, and it's almost as if this is the membrane, this is the vesicle, it fuses, and then opens up on the other side, and that's what allows the neurotransmitters to come out of. I'm wearing gloves because I have medicine on my fingers, so don't be alarmed. Also, they will bind to receptors on the postsynaptic cell. All right, so after they're released into the synaptic cleft by exocytosis, the neurotransmitters will bind receptors on the postsynaptic cell. And some of these receptors can be coupled to ion channels. So you hit the receptor, channels open, that can trigger an action potential or signaling. That's electric of nature, ionotropic signaling. And you could also have it be a more metabolic process like you would see in smooth muscle contraction, where you have, for example, a G protein coupled receptor associated with the receptor. And when acetylcholine, for example, which is just one neurotransmitter, is going to bind the acetylcholine receptor on the smooth muscle cell, it'll activate a G protein that ultimately leads to contraction of the smooth muscle. And so there's that. And in some cells, there's going to be gap junctions made by proteins called connexins that allow cytoplasm to cytoplasm transfer. All right, so these whole channels are connexon channels. Each individual protein is a connexin, and you can see how it forms these gap junctions. Why are they called gap junctions? Because they bridge the gap between cells and they allow direct electrochemical transmission from cell to cell. And that's going to be very important for all or nothing processes like heart contraction. All right, so over here on the left, we have an ionotropic receptor. So you can see here, you have, you have your axon, you have your action potential, it's happening, you have some calcium release not shown here, and then the vesicle fuses with the membrane, the neurotransmitter comes out, and it'll bind to, in this case, an ion channel. All right, it's ion channel associated. All right, so the nicotinic acetylcholine receptor channel activates in skeletal muscles. You get membrane depolarization, an action potential, and a muscle contraction. Versus in a metabotropic receptor, you have your electric stimulus. The signal travels down the axon. You get release of the vesicles contents into the synaptic cleft, and it binds to a G protein complex, which leads to activation of the receptor. So it doesn't bind the complex. The receptor is associated with the complex, and then once the receptor is bound, the complex releases the alpha component, and that causes beta gamma component to come here, as you can see, and that beta gamma component is going to drive these inward rectifier potassium channels, and that hyperpolarizes the membrane and that causes a decrease in heart rate. Okay, but I don't want you to memorize this. The whole point of this diagram, I'm just showing you two examples of how in an ionotropic receptor it's ion channeled. It's an ion channel that's coupled to the acetylcholine receptor, and that leads to muscle contraction in an electric process. Over here, you're looking at the muscarinic effect of acetylcholine, where it's binding to a receptor associated with the G protein, and then that G protein causes a series of actions that are metabolic of nature, but it's not directly gated to to an ion channel. And over here we see the overall process of what's going on. We can see that a neurotransmitter has to be synthesized and packaged in vesicles. Now there's an exception to this. Peptide neurotransmitters are preformed, they come down the axon, and they're released formed. They were always formed, they were always in there, they're just released. The non-peptide neurotransmitters, what happens is the vesicles are empty. And then once the vesicles are here, the neurotransmitter gets packaged in the vesicles. All right, so that's an important distinction. Peptide neurotransmitters are preformed, whereas the non-peptide neurotransmitters, kind of their vesicles have to mature in this region called the active zone, which on electron microscopy you might see as, you'll see a membrane and then like a really dark area representing a high density of vesicles. It's in that active zone, which would be somewhere over here, that the vesicles mature and actually get the neurotransmitters put in them. All right. So an action potential will arrive at the presynaptic terminal, and neurotransmitter molecules will be synthesized and packaged in vesicles. All right. So that's all sort of happening. The neurotransmitters being synthesized, the action potential, and that's sort of happening in the background. Right? This is happening in the background. It's an ongoing process, and then they come down, they mature for the non-peptide neurotransmitters, like acetylcholine, for example. They'll come down here, the vesicles will mature, they'll be packaged. In the meantime, an action potential can come on through. Once the action potential comes through, that's going to cause opening of voltage-gated calcium channels. Now, why are they called voltage-gated calcium channels? The reason they're called voltage-gated calcium channels is because they're gated to the voltage. So when the action potential arrives and depolarizes this membrane, that will allow the calcium channel to open. So that active depolarization allows the calcium channel to open. And when that calcium channel opens, calcium, through a process that we're going to discuss later, causes the vesicles to fuse with this membrane. All right, so the synaptic vesicles fuse with the presynaptic membrane, as you see here, and that allows them to bind neurotransmitters. All right, it allows them to release neurotransmitters that are going to bind the specific receptors, and that will activate the postsynaptic cell. Now, there's a couple things that happen. The neurotransmitter can either just diffuse away from the synapse, so it doesn't have an effect anymore, or it could be broken down. And an important concept for this is acetylcholinesterase, and we're going to have a lot of pharmacological targets that either agonize or antagonize acetylcholinesterase, and we'll talk about those towards the end. But again, I just want to summarize the overall process that occurs. You have vesicles that come down here along the axon through kinesins. This is called anterograde transport. So it comes down along the axon towards the terminal bouton, which is this region here. In the presence of a depolarizing current, the voltage-gated calcium channels will open. In the meantime, these vesicles have been maturing and they've been having neurotransmitters packaged into them. So by the time this channel opens, they're ready to fuse and perform their function. All right. What I want you to note is sort of the anatomic relationship between the presynaptic axon, which is this here, and its boutons, which are these areas here, the basal lamina, which is here, which is very rich in acetylcholinesterase. And that's very important to prevent spasticity. Acetylcholinesterase is present in high concentrations in this basal lamina, this area here, between the folded membrane of the neuromuscular end plate and the the terminal bouton. So you can see there's a very high density of synaptic vesicles, and they're just hanging out at the bottom in the active zone, waiting for that calcium stimulus to come along to let them fuse. So once you get the action potential, these will fuse. This will enter the neuromuscular junction, signal these nicotinic receptors, and then the muscle will contract. So this is for skeletal muscle that we're talking about. So you can see the process of a muscle contracting can be interfered with at the level of the spinal cord, at the level of the nerve cell body, at the level of the axon, at the level of the synapse, the level of the presynapse, and the level of the postsynapse. So there's a lot of disease states that can occur in any single one of these places that can interfere with muscle contraction and muscle function. All right. The main thing I want to point out here in summary on this slide, though, is how all these vesicles are concentrated in the active zone and won't fuse until calcium signaling happens. There's a sensor called synaptotagmin that we're going to talk about later. It's synaptotagmin, synaptotagmin. We're going to talk about it later, and it's the calcium sensor, and it's a part of the vesicle apparatus. So these are all docked. They're very intimate to the presynaptic membrane, but they aren't fused with it yet. They will not fuse unless the synaptotagmin senses calcium. And when it fuses, it'll release the neurotransmitter in here, it'll bind, there'll be some function, and that neurotransmitter is quickly broken down by acetylcholinesterase. So you can see here that the peptide neurotransmitters are made way early. They're ready from the get-go. Whereas the non-peptide neurotransmitters aren't really developed until they get to here. So these are clear vesicles. All right, so the non-peptide neurotransmitters is synthesized over here in the nerve terminal, much closer to the active zone. This is where they mature. Whereas a peptide neurotransmitter is already present. All right. So let's talk a little bit about the process. Okay, so the vesicle is going to dock near the presynaptic membrane. Okay, and I'm going to review this 3 or 4 times, the slide 3 or 4 times. So don't stress about getting it on the first time. Here's what we'll do. First, we're going to define some terms. We'll go through what's going on in the pictures. Then we'll re-summarize it again. All right. So SNAP stands for soluble NSF attachment protein. NSF is an ATPase that's going to break down the vesicle complex. All right. SNARE is the SNAP receptor. Okay. So it's the receptor for this factor. The VAMP, synaptobrevin, is a vesicle-associated membrane protein, also called a VSNARE. All right. So it's part of the presynaptic membrane that interacts with the, what do you call it? Why am I blanking? With the vesicle. Syntaxin 1 and SNAP25 are examples of T snares, all right? And synaptotagmin is the calcium sensor for exocytosis, all right? So let's go through everything that's going on here. You can see the docking stage, SNAP25 and syntaxin, the T snares that are the terminal snares. That's what the T stands for. They're on the terminal membrane. The snares on the terminal membrane are not bound. Okay, so the docking is about to occur. You can see you have your calcium sensor here, synaptotagmin. You have synaptobrevin, which you're going to see in a second is going to be your V snare. So your T snare and your V snare are going to interact. All right. So the vesicle with synaptotagmin and synaptobrevin, which is the V snare, docks at the active zone of the presynaptic membrane in proximity to SNAP25 and syntaxin 1. All right. So I described what's going on in the picture. I described what's going on in the caption. All right. What's going to happen is that you're going to have some proteins that are going to bind the V snare and T snare and bring them together. Don't worry about this MUNC18 protein. You don't need to worry about that. What I want you to recognize is that this is a highly thermodynamically favorable process. So once the T snare and V snare come together, it's going to be a very thermodynamically stable process. In fact, so thermodynamically stable that this could fuse immediately if something else didn't happen. All right. So to summarize this, it's called the priming stage 1. The vesicle has docked near the membrane, the snare complex is assembled, and the components coil around each other, and it's highly thermodynamically favorable, and the vesicle is on track to fuse unless something else happens. A good fellow called complexin comes in, and it's sort of like a world-class wrestler that's going to come in and grab the snare complex and stop it. All right? So what's going to happen is it's going to stop it. Complexin is going to insert into the complex to prevent the fusion from spontaneously happening. Okay? And then the vesicle is stuck like this. This is priming stage 2. Unless synaptotagmin senses calcium, nothing is going to happen. You can see the complexin is right here. It's kind of like a lock. You can see it's just wrapped around this. Nothing more is going to happen. All right? Now, calcium will enter the nerve terminal. You had your action potential, etc., etc. We will do a lecture discussing action potentials as well. But calcium will enter the nerve terminal and bind to synaptotagmin. Like we said, synaptotagmin is the calcium sensor. And when that happens, it's going to bind the phospholipids in the membrane And by binding the phospholipids in the membrane, it's going to cause this like torsion on the snare complex. Look how neat it is. Now this synaptotagmin is going to bind into the membrane and sort of force off the complexin by doing that. All right. And once complexin is removed, that's it. The process, that highly thermodynamically favorable process of fusion, goes to completion and the fusion pore opens. All right, you get fusion and formation of the fusion pore. Now you have PMCA and calcium PMCA channels, which are, don't worry about it right now, but think of it as how it gets calcium out of the cell. Calcium is very toxic to cells, so you want to get it out as soon as possible. So after the action potential and calcium induced vesicle fusion, the calcium gets taken back out, and the intracellular concentration of calcium is going to fall rapidly because it's either being sent back out of the cell or absorbed in the mitochondria. But what's free inside the cell is going to decrease rapidly, and that causes synaptotagmin to dissociate. Remember, it's a calcium sensor. It doesn't sense calcium, it comes off. So that NSF ATPase is going to disassemble. At that point, when synaptotagmin comes off that NSF and ethylamide sensitive factor, you're going to have release the snare complex. And why do you need ATP to do it? Because it's so thermodynamically favorable that you need to invest energy to break it apart. That's why there's so many mitochondria present in this region at the synapse, because this is a very thermodynamically unfavorable process, breaking up the complex. So you need to provide exogenous ATP. So in summary of this slide, NSF is going to do its ATPase behavior to break up the complex, and that's why mitochondria are needed. And how does that occur? Because synaptotagmin comes off. Why does synaptotagmin come off? Because the calcium levels in the cell have now decreased. So that occurs, the snares like disassemble, and you get clathrin-coated endocytosis, and you just recycle the process over and over again. All right. So this is the acetylcholine receptor. The thing I want to really point out here that's of interest is notice that there's a mouth to the pore and a gate. There's a mouth and a gate. So you can have things that competitively inhibit over here. So you can see you need 2 acetylcholine to bind these neurotransmitter binding pockets. The acetylcholine receptor needs 2 acetylcholines. So you can provide a, a competitive antagonist like curare, and that's going to compete with acetylcholine for these binding pockets to inhibit the receptor, and that's competitive antagonism. And you can also have non-competitive antagonism, which will be more down here in the mouth of the channel, preventing anything from coming through, so that even if acetylcholine binds, it doesn't matter because you'll have something non-competitive over here blocking the mouth of the channel. And we'll talk about some agents that do that. We will discuss that. Additionally, something that I want to point out is that you can agonize these channels. The same way you can antagonize them, you can agonize them. So you can see you have a lot of levers to pharmacologically manipulate this acetylcholine receptor, which is quite ubiquitous in the body. So from a general clinical perspective, the things we're concerned with are either interfering with metabolism of acetylcholine or interfering with the vesicle exocytosis and the drugs you provide to do that and the toxins that interfere with that. We're concerned with the degradation of acetylcholine by the acetylcholine esterase, and these can be targeted either pharmacologically or by a toxin. And we're also concerned with activation of postsynaptic receptors, which can be inhibited or enhanced pharmacologically, and very importantly, can occur as an autoimmune or paraneoplastic phenomenon. The presynaptic channels can be affected as well. So not just I would want to add here, not just activation of the postsynaptic receptors, but the presynaptic channels as well. All right, that's going to be very important when we talk about the myasthenic syndromes. So what is a myasthenic syndrome? It means weakness. Myasthenia means weakness of the muscles. In congenital myasthenic syndrome, it's a wide spectrum of conditions and mutations, And I'm pointing it out because it highlights the point that we were talking about earlier, what we're concerned with clinically, because you can get congenital myasthenic syndrome from mutations in the release of acetylcholine, from mutations in the availability and the metabolism of acetylcholine, and mutations and defects in the functioning of the acetylcholine receptors. So you can see if any one of these processes go wrong, you can get a myasthenic syndrome. And in congenital myasthenic syndrome, these processes occur from birth. So a channel is either open or a channel is closed. So if you look at the example of acetylcholine, when 2 acetylcholine binds, the channel opens, right? So 1 agonist doesn't matter. 2 agonists, you get an open channel. And the issue is that you can close this channel or you can block it. All right. So competitive inhibitors will compete for these sites. Close A1C, A2C, then it opens. It'll prevent there from being 2 acetylcholines. A non-competitive inhibitor will just block. So tubocurarine, and you're going to see a lot of similar drugs to this on your anesthesiology rotation. Tubocurarine will prevent the binding of acetylcholine by taking its place on the binding site, as we discussed earlier. And lidocaine similar drugs, so these are the lidocaines, procaine, etc., they non-competitively inhibit the channel by interfering with the flow of ions across the channel. So they bind near the mouth and prevent anything from passing through. And you can see here, lidocaine, it's it's all or nothing. When the lidocaine is in the mouth of the channel, nothing gets through. So you have these brief repeated closures like, oh, it's closed, oh, it's closed, oh, it's closed. And you have to remember that everything is probability in pharmacology. What are the odds? Depends on the amount of lidocaine you're using. What are the odds that lidocaine will be present molecularly present in the, what do you call it? In the synapse. Not in the synapse, in the receptor to non-competitively inhibit it. All right, so this is the normal. It goes closed and open, closed and open. And lidocaine, you get this shaky activity and no signaling can really occur because of these open, close, open, close, open, close, because it's non-competitive. It just blocked the channel, period. And that brings us to myasthenia gravis, which is a very important clinical condition that you absolutely must know everything about. For step 1 and step 2. It has a bimodal distribution. It's the most common adult form of myasthenic syndromes, and the peak incidences are usually starting the 20s, and typically it's a young woman with thymic hyperplasia and weakness that gets worse throughout the day, versus in the 60s, which the older patients who will present for the first time with myasthenia gravis is usually in the context of thymic cancer. In both scenarios, the cells of the thymus contain nicotinic acetylcholine receptors, and the immune system recognizes the hyperplastic or cancerous cells and develops autoantibodies against these receptors. That causes crossfire. And so instead of targeting what it's recognized as abnormal on the acetylcholine receptors, the nicotinic acetylcholine receptors in the thymus, what it's going to do is it's going to recognize the nicotinic acetylcholine receptors in the postsynaptic nicotinic skeletal muscle receptors. So you normally have your synapse, right? Your postsynaptic area, and then your muscle, right? The neuromuscular junction, and the muscle is here. So what's going to happen is this receptor on this side, so let me draw a receptor in purple. All right, so let's say this is a receptor. This is neurotransmitter, etc. What's going to happen is there's going to be autoantibodies that block this off. Okay, and it's going to prevent the binding of the neurotransmitter to the postsynaptic receptor, and that means that the neuromuscular junction is inactive. This motor end plate is not stimulated. All right. And it's going to be autoantibodies that block this off. A common presentation is the weakness of extraocular muscles. So usually it's going to be like eyelid, like someone will be like this, and then this will be, and then this will be this, and then this is droopy, or the eyelid is lagging, or this eyelid is lagging, or there's a slight. So it's weakness in some of in the facial muscles, typically the extraocular muscles. So you'll have sometimes double vision, proptosis, so lid lag. And it gets worse as the day goes on. And the weakness is usually worst at night because, think about it, you'll have a limited amount of acetylcholine, and acetylcholinesterase is active. So as the day goes on, you're exhausting more and more of your acetylcholine, and you have even less and less to compete with these autoantibodies, which are competitively inhibiting the binding site. I actually don't know if it's competitive or non-competitive. The point is the antibodies block out the neurotransmitter. So here's what normally happens at the neuromuscular junction. You have your acetylcholine, it comes through, you get this neuronal impulse, and then it enters the, what do you call it? The postsynaptic cleft. You get binding to, what do you call it? The postsynaptic membrane and the acetylcholine receptor, and this acetylcholine receptor is coupled to an ion channel, and sodium is going to come through, and that's going to cause an action potential. At the end of that action potential, the muscle contracts. And myasthenia gravis, here is the pre-action potential area. So versus here, the vesicle is just comes on through and it hangs out. Here it comes on through and it hangs out, and the autoantibody, you can see, is completely blocking this off. All right. And the autoantibody causes the receptors to be degraded. So here's the function of how it works. The autoantibodies cause the receptors become unavailable and degraded at some point. But the point is they're not available for acetylcholine is the bottom line, regardless of what the function is. And you can see that the neuronal impulse in myasthenia gravis doesn't matter, because even when you release all this acetylcholine into the cleft, you can't have sodium influx into the muscle membrane. And if sodium doesn't influx into the muscle membrane, you don't set off the action potential. So a lot of people with myasthenia gravis will have a thymoma, thymic hyperplasia, etc. So first, let's review the anatomy real quick. So here's the right lung, here's the left lung, and this is where the heart would sit. And directly above the heart is this thymus. And in adults, it's going to be more of like fatty tissue, but it can still be present. It can be completely gone by late adulthood. But the point is, you can see why thymic cancer can be problematic. Here's the thyroid gland. Here are the left common carotid artery, the internal jugular vein associated with it, the left subclavian vessels. Here's the superior vena cava coming behind it, and it'll go into the heart. You have your windpipe right here in the middle, and you have some nerves. So you can see this is the vagus nerve. This is probably going to give off the recurrent laryngeal nerve. So when you're doing surgery on the thymus, if you accidentally nick this recurrent laryngeal nerve, you'll have voice hoarseness, etc. That's besides the point. What I'm trying to show is the location of the thymus, so that let's say you get a question stem and it kind of looks like myasthenia gravis, and then they show you a picture of this CT scan, and that's why I was showing you this here. You can see, as we would expect, remember the thymus, a part of it is sitting over what? Right over the superior vena cava. All right, and over right here behind it, it's going to be the aorta somewhere. So if we look here at this level, this is the mediastinum. All right, so this is the sternum. These are the ribs. These are the ribs, these are the ribs, these are the ribs. Here's the vertebra, the paraspinal muscles. And as you come here, you have a pulmonary artery. So this is the right pulmonary artery. That's the left pulmonary artery. And over here, you have the ascending aorta. And this is the descending aorta. So that arc is happening right over here. And here's the superior vena cava. So this mass over here is going to be a thymoma. All right, so this is a thymoma. So if you see a CT scan like this, or they might just give you this CT scan, something like this on an exam, they can give you the CT scan and they can ask, which of the following conditions would likely be present, or which of the following antibodies, autoantibodies, would be present in this patient. You have to recognize that they are autoantibodies against the postsynaptic nicotinic acetylcholinergic receptor, and that there's going to be crossfire because it's expressed on the thymus. There's going to be crossfire, and it's going to affect the nicotinic receptors on muscles. All right. And Lambert-Eaton myasthenic syndrome is an autoimmune disorder most seen in those with comorbid lung cancer, especially small cell carcinoma. Small cell carcinoma has a ton of paraneoplastic syndromes. This is one of them, and a very high yield one. About 30 to 40% of people with LEMS have small cell carcinoma. Now, one way you differentiate this from myasthenic syndrome, because it's the same clinical presentation at first. So while in myasthenic syndrome, there's targeting of those postsynaptic nicotinic receptors, in Lambert-Eaton syndrome, there's more emphasis on the presynaptic calcium channels, so preventing the vesicles from ever being released. In myasthenia gravis, the problem is on the postsynaptic side, where the receptors are no longer available for acetylcholine. In Lambert-Eaton, you have your nerve, your terminal bouton, and you have your calcium channels, and those are supposed to, during the action potential, that's supposed to activate. Remember, they're voltage gated calcium channels. They should activate, allow calcium through, and cause the vesicle to fuse with the presynaptic membrane and dump all the neurotransmitter out. However, in Lambert-Eaton myasthenic syndrome, those channels are targeted by autoantibodies, which prevents fusion of calcium, which prevents the release from the vesicle into the synaptic cleft to begin with. And that defines the entire difference in the pathophysiology and the clinical presentation. Because while in myasthenia gravis, you have a scarcity of receptors to bind to. So as you work, it's like, oh my God, we don't have any more acetylcholine to spare. And part of the treatment is going to be to increase the amount of acetylcholine in the synaptic cleft so it can compete with the antibodies. In Lambert-Eaton, that won't work. And in fact, in Lambert-Eaton, repetitive movements get stronger. In myasthenic syndrome, repetitive movements get weaker as you deplete acetylcholine due to acetylcholinesterase. In Lambert-Eaton, the muscles get stronger with each repeated movement. Why? Because every time you do a movement, you just got a little more neurotransmitter, and those repeated movements get more and more and more neurotransmitter because the receptors are working on the postsynaptic cell. It's the presynaptic cell that's the problem. So those repeated small contractions allow you to generate more and more neurotransmitter in the junction. All right. So the protein is called CAV 2.2, and that's involved in Lambert-Eaton myasthenic syndrome. It's the calcium voltage-gated calcium channels on the presynaptic acetylcholine. What do you call it? The presynaptic terminal. Not presynaptic terminal. Presynaptic membrane. Due to the nature of the disease in Lambert-Eaton myasthenic syndrome, repeated stimulation causes an increase in the amount of acetylcholine in the junction, leading to a better function of repeated movements. In contrast, in myasthenia gravis, actions are difficult to repeat because there are not enough receptors to bind due to autoantibody displacement. And over here, we can see it. Normally, again, nerve, vesicle comes down. Hello, acetylcholine, having a good time. Everybody's happy. Here are your calcium channels, and that's what caused calcium-bound synaptotagmin, and then that caused the fusion to occur, and everyone's happy, right? Happy days. In the pathologic state, what's going to happen is that even when you notice that not a lot of vesicles fuse. Why? Because you have an autoantibody that's binding to the calcium channel. This calcium channel is implicated, all right? And it's inhibited, and that causes a very weak release of neurotransmitter. And one therapeutic strategy involves activating this potassium channel to keep the calcium channels open longer, the ones that are not inhibited, to keep them open longer. Because remember, what's going to close the calcium channel is the repolarization by the potassium, because that's how an action potential works. Sodium depolarizes, potassium repolarizes. And if you can prolong how long it takes to repolarize and keep the voltage from coming into the range where the calcium channel closes, right? The potential comes up, the voltage-gated calcium channels open, potassium starts working, and then the potential comes down, and then the calcium channel closes. So the treatment of Lambert-Eaton is going to be to try to keep those channels that are active, to keep them as open as possible. So what you do is you target those potassium channels, you keep the potassium from coming out of the you keep potassium from hyperpolarizing the cell, and that allows the calcium channel to stay open for longer. And over here we can see there's a bunch of toxins. There's a few we'll talk about in detail. I just want to show where they act. So you can see that the sodium channels are inhibited by the tetrodotoxin, saxitoxin, etc. Those are called the guanidine toxins. You can see here that potassium channels are inhibited by dendrotoxin, that acetylcholine release is inhibited by tetanus and botulinum, and at different places. And that's how their clinical presentations are. and we'll talk about that. Acetylcholinesterase can be inhibited by the stigmine molecules, particularly neostigmine, or permanently inhibited by diisofluoroprophosphate. I forget exactly what DFP stands for, but it's one hell of a drug, and it's probably one of the most lethal weapons. So sarin gas, which is banned by the Geneva Convention, is DFP, or it's derived from DFP. And then you can have inhibitors of the acetylcholine receptor channel like curare or bungarotoxin, namely curarine. And then you can agonize this channel, and we'll talk about how that could cause a problem. You can agonize this channel with acetylcholine and nicotine. All right? So what dendrotoxin is going to do, it's going to blockade the presynaptic potassium channels, and that prevents repolarization of the synaptic membrane. And then as a result, it's going to be like what we did on purpose with Lambert-Eaton syndrome. We purposefully targeted this channel to prolong the action potential and to keep the calcium channels open for longer. And that's exactly what's going to happen here. So dendrotoxin is going to cause a prolonged action potential, so a more of a spastic paralysis. All right. In botulism, a single molecule of botulin toxin can destroy the snare complex. Remember the snare? Botulin destroys the snare and the presynaptic acetylcholinergic receptor. So botulism, the botulin toxin acts at the level of the synapse, and it targets the snares at that synapse. And it's the presynaptic acetylcholinergic, snare vesicles that are targeted. And the first manifestation, and remember, just one molecule can destroy the complex in that terminal, and then you're donezos. And at first, it's going to manifest as dry mouth, double vision, difficulty swallowing, etc., GI upset. So first, it's going to involve the autonomic nervous system, then it'll involve the skeletal form, and that's going to require mechanical ventilation at some point. The mortality rate is about 20%. In tetanus, it's a similar process. It's going to affect the snare complexes as well, but it's acting at a different spot. It's not acting at the neuromuscular junction. So botulism is the botulin toxin acts at the neuromuscular junction. All right, and it acts at the presynaptic and postsynaptic acetylcholinergic, right? These are cholinergic signaling. The overall line with botulism is that acetylcholinergic signaling is disrupted. All right. In tetanus, it's targeting the spinal cord. So there's inhibitory interneurons. So you get an inhibition. So normally your spinal cord inhibits your muscles and keeps them relaxed. So you get inhibitory signals by default from the spinal cord, which keeps your muscles relaxed and not spastic. If you inhibit those inhibitory interneurons, it's like a negative of a negative is a positive. So what's going to happen is that you inhibit glycine and GABA in the spinal cord through the tetanus toxin. It'll interfere with the snares of those neurotransmitters instead of acetylcholine. And that causes a spastic paralysis, because if those inhibitory vesicles are inhibited, inhibition of inhibition is a positive. And that causes a spastic paralysis. And that's why the DPT vaccination is important. That covers diphtheria, pertussis, and tetanus. And the Tdap booster can protect you. But some people, and as I've begun to practice medicine and seeing it in clinical practice, a lot of people don't have a Tdap. Especially the older you get, for some reason I've noticed that some of my older patients don't have Tdap more than I thought would. And that's sort of part of what I do when I'm meeting a patient for the first time in the family medicine or internal medicine, environment. I always ask about meningococcus vaccine. If they're young, I'll always ask about pneumococcal vaccine in somebody who's, the age that it applies to. We're not going to go through the guidelines right now, but it's like 65. I always ask about shingles. I always ask about Tdap. All right, because you can still get tetanus and pertussis. And what you will see everyone do in the ER, this is standard practice. If someone comes in with a cut injury or steel injury or like an open wound, one of the first questions I've seen the ER docs I work with ask, they're going to say, do you know when you got your last Tdap? And if they're not sure about when, they usually encourage it. All right, and here are a bunch of agonists we can use. These are all anesthetics. All right, these are all different kinds of anesthetics, except for nicotine. So succinylcholine, what's first going to happen, and if you're ever in the OR and you're on anesthesia, or if you're just on the operating side, pay attention to when the anesthesiologist induces. So first thing that'll happen is contraction and then relaxation. Why? So succinylcholine is an agonist. So why are we using it as an anesthetic? What it does is that it's going to prolong the open state. So succinylcholine binds, and when it binds, it opens up the channel and it keeps the channel open. If the channel never closes again, the muscle doesn't contract again, right? So you get an initial contraction, those fasciculations, and then relaxation, and that's succinylcholine. Now, pancuronium is really great because it's a competitive cholinergic antagonist that's selective to the muscle receptors. All right, it's not an agonist, it's an antagonist, but it's selective to the muscle receptors, so you don't get, all those autonomic side effects. We talked about sarin, DFP. It's an irreversible acetylcholinesterase inhibitor. What's going to happen is you're going to build up so much acetylcholine that's going to cause paralysis. It's the same idea as a succinylcholine, except that's reversible. This reversible, and it's an agonist of the receptor. Here, the problem is that you will have an extraordinary abundance of acetylcholine and toxicity from that, because you're not going to be able to relax, and it's a chemical warfare weapon. Neostigmine is an inhibitor of acetylcholinesterase, and that's going to increase the availability of acetylcholine at the synaptic junction. So what disease do you think this is going to be great for? Myasthenia gravis. So again, myasthenia gravis, very, very, very important condition, because they could put a question stem where you have to diagnose myasthenia gravis, and they could say, which of the following would be a contraindication to the treatment, right? So they might give you somebody who has myasthenia gravis and they'll have asthma. Okay, why would neostigmine be relatively contraindicated in someone with asthma? Remember that antimuscarinics are used to treat asthma. So a muscarinic would make it worse. So providing neostigmine, which is going to increase the amount of muscarinic signaling, is going to cause bronchoconstriction, and in someone with asthma, that can be problematic. Or let's say the patient has heart block. The patient is like a 65-year-old man who has thymic cancer, and you get a CT scan, and you're like, which of the following would be a contraindication to the treatment, right? So it's sort of like a third order question. They want you to recognize that the clinical vignette of myasthenia gravis, which is weaker as the day goes on, especially with the extraocular muscles, they'll give you a CT scan with a thymoma, with his thymic cancer on it, and they'll say, which of the following would be a contraindication to the treatment? And I think that could be more of a step 2 question than step 1 question. But you have to recognize, okay, this patient who has, for example, let's say he has heart block, that this might not be a good drug to use in a specific patient. So you'd have to weigh the pros and cons carefully. Because what's the con of not treating myasthenia gravis? Myasthenic crisis. And we're going to talk about that. So this is contraindicated. So neostigmine is also contraindicated. This is an absolute contraindication in obstruction. So think about what would happen if, let's say, you have a small bowel obstruction, because of, let's say, you had a prior abdominal surgery and you have all this scar tissue, and the small bowel has gotten entrapped around it and is now obstructed. And then you give something that's a muscarinic. What do muscarinics do? They cause increased digestion and urination, etc. So what's going to happen is it's going to cause contractions. And what you get, you'll have these contractions against an obstruction, which is not productive. All right, so it can make the problem worse. So that's why you would not provide neostigmine in an obstruction. At the end of the day, all the contraindications come down from acetylcholinergic signaling, so you can use your best reasoning. So if you have a patient with bradycardia, well, if I provide a muscarinic, you're going to have even more vagal output on the heart. You're going to slow the heart rate down even more. You don't want that. If somebody has asthma, they're already bronchoconstricted, and we treat asthma with antimuscarinics as one of the therapies. It's not first line, but it's one of the therapies. But if you provide an agent that causes bronchoconstriction, well, you've just opened a whole can of worms, right? So you have to think about the pros and the costs, because the problem is you don't want to get myasthenic crisis. That is what that's the feared complication of this. So people confuse myasthenia gravis and multiple sclerosis. So I just kind of want to differentiate the two. First of all, myasthenia gravis is diagnosed by the antibodies, right? And then you do a bunch of tests that pretty much show that with repeated contractions, the muscle gets weaker, or prolonged contraction, the muscle gets weaker, and an extent more than what would be normal. All right, and then you would image to look for a thymoma because so many people have these masses associated with myasthenia gravis. So the pathophysiology of myasthenia gravis and multiple sclerosis is very different. So while multiple sclerosis, it's the myelin sheath that's targeted, it's the muscle receptors that are targeted in myasthenia gravis. In the multiple sclerosis, it's like more of it's cell-mediated damage to the myelin sheath. All right, so it's an autoimmune, they're both autoimmune, but in multiple sclerosis, it's T-cell mediated. And the pathophysiology of myasthenia gravis, it's going to be it's about type 2 reaction, where the autoantibody directly causes interference with the, what do you call it, with the functioning of the receptor. And in multiple sclerosis, it's direct T cell mediated damage to the myelin sheath. Now, while both of them can involve weakness, multiple sclerosis has a remitting relapsing. It starts and stops, and you can have a whole garden variety of symptoms, which are down here, and we're not going to go into them. All right. Whereas in myasthenia gravis, it's continuous with weakness that gets worse with activity but gets better after resting. Whereas multiple sclerosis is relapsing, remitting. You have multiple weakness events or neurologic deficits that are separated in time and in space. All right? There's no cure for either one. Okay? That's the difference between that's the main difference between the two. It's the pathophysiology. All right? So what you're scared of most is myasthenic crisis. What happens in myasthenic crisis is you get bulbar weakness and ventilatory muscle weakness. All right, so you get a bunch of problems that end up leading to pneumonia because of impairment of your cough and your swallowing. You get collapse of you get all these extra secretions and collapse of the lung, and then that can be complicated by pneumonia. And then on the other side, what's the weakness of the lungs itself will decrease the residual capacity of the lung, which causes increased hypoventilation and dead space, ventilation perfusion mismatch, hypoxemia, hypercapnia, and respiratory failure. And I'll come back to this sequence in a bit. And how are you going to manage it? It's going to go to the ICU. Notice all roads here lead to the ICU. So whether it was confirmed or not confirmed, they're going to the ICU, right? You're going to have to do a bunch of critical care stuff that's listed over here, but the mainstay of treatment, and this is what I wanted to come to. This was the main thing I wanted to come to: ventilatory support. So myasthenic crisis is a crisis. It is a medical emergency. The patient will not be able to protect their airway, and we'll talk about the consequences over here. So first off, on this side, the patient cannot protect their airway. Okay? So unprotected airways, I'm going to write here, UA. Unprotected airway. So you're going to get extra secretions, impairment in the cough and swallow reflex, collapse of the lung, choking, increased upper airway resistance, and work of breathing, which means it gets harder to breathe because there's more resistance because of all this goop that's in the lung, and then that can be complicated by pneumonia. But ultimately what it can lead to is not enough oxygen getting in, and then we'll talk about this bottom part later. So let me put a little trapezoid around that. On the other side, you have the ventilatory side, okay, the ventilatory muscle weakness. And what that means is that the lungs will not be powerful enough to exchange an adequate amount of oxygen. So you have the lungs here, trachea, okay, trachea, main stem bronchus. This was kind of a gross, very distorted gross anatomy of the carina and the two main stem bronchi. But the point being, normally, I'm just going to draw two things here. These are not alveoli. I'm just using this to represent all of the alveoli in the lung that the bronchus is feeding into. This space should normally exchange oxygen, right? Well, if it's filled with goop, you have less space to exchange. So all this purple represents CO goop, all right? when you can breathe deeply, you can exchange a lot of the useless air for fresh oxygen. Okay? However, when you have decreased ventilatory muscle weakness, you get hypoventilation. So that stagnant air does not get exchanged and it kind of just hangs out over here. And why is that called dead space? Well, it's called dead space because you have all these capillaries that are coming in to get fresh blood, right? It's fresh blood with fresh oxygen, except it's not fresh oxygen because you're hypoventilating, because you have ventilatory muscle weakness, because your ventilatory muscles are skeletal muscles, because you're in myasthenic crisis, you don't have enough acetylcholine to breathe. Your ventilation gets weaker and weaker. You get a lot of stagnant air in here. You get dead space because this does not contain oxygen and it's a waste of perfusion, and that's what VQ alteration means. You have this anatomic dead space and VQ alterations, and which are mismatches in the ventilation and the perfusion, and that leads to decreased oxygen in the blood and increased carbon dioxide, which are both problematic. And that's respiratory failure, and that will kill you. That will just straight up kill you, no questions asked. So that is why it's a medical emergency. It's treated in the ICU, and you have ventilatory support. All right. As you can see here, this is sort of the flow chart for treating myasthenia gravis. First, you get the diagnosis and your autoantibody status is confirmed. Do they have autoantibodies? Do they not? Okay. Now you can decide, are we going to treat with acetylcholinesterase, and we are going to treat with acetylcholinesterase, but are we going to treat with or without immunotherapies? Sorry, not treat with acetylcholinesterase, with the inhibitors of acetylcholinesterase, neostigmine, what we discussed earlier. So you're going to treat with neostigmine on its own, or you're going to put some immunotherapy as well. And then you're going to do mediastinal imaging to look for an associated thymoma. Now, if there is one, you're going to remove it. If there's not, you're going to do a separate workup, okay? So do they have antibody positive myasthenia gravis? If they don't have antibodies, you're not going to remove the thymus. If they do have antibodies, you're going to have to, that's like a case-by-case basis, and you can see each patient has their own thing going on. If young patients, you'll probably favor the thymectomy. In middle-aged patients, you have to think about how bad is it interfering with their life, what is the risk of the procedure for this particular patient, and for older patients, you might say, you know what, the odds that there's something going on here are medium probability, but even if we did want to remove this patient's thymus, there's a lot of morbidity associated with it, and maybe the benefits aren't as good, right? So for somebody who's older, you might not proceed with a thymectomy. Someone who's younger, you might be more aggressive. Someone in the middle range, it's going to be case by case, and as you get older, surgery becomes more and more risky. All right, anesthesia. So procaine and lidocaine will block action potential propagation by blocking sodium channels in the peripheral nerves, and that lets you be very targeted. Regional anesthesia involves injecting the spinal cord, all right, and that you prevent signaling from that specific dermatome, reducing the sensation of pain. And this is very commonly used on labor and delivery as an epidural to prevent pelvic pain. And regional anesthesia is used very often um, in local, not regional anesthesia. Local anesthesia is used relatively often in dental procedures by targeting the inferior alveolar nerve. So that's running down over here. So you can see there's a bunch of nerves over here. Don't stress out about the anatomy right now. All I'm trying to point out is that a dentist can target this nerve right here with lidocaine. That's going to inhibit the sodium channels. Because the sodium channels are inhibited, you will not get an action potential, you will not get neurotransmitter release, and you will not get the sensation of pain. All right. Now, benzos are used as sedative agents that increase the activity of the postsynaptic GABA receptors. All right, by increasing the activity of the postsynaptic GABA receptor, that decreases the excitability of the postsynaptic cell because GABA is inhibitory. So if you increase how active the inhibition is, that causes an overall decrease in how excitable the cell is. Propofol is not a benzodiazepine, but it enhances GABA while also blocking sodium channels in tandem. It's very commonly used in scope procedures. GI docs use propofol for their sedation quite often. And sometimes they may or may not give Xanax alongside it or another. Anyways, different can of worms, not the focus of today. General anesthesia is induced either through an IV or through inhalation and does not cut off pain sensation. You have to administer it with analgesic agents like fentanyl, because remember, it does not cut off pain. So you have to treat pain. All right. In the post-operative period, you won't use fentanyl. You'll probably use morphine. Well, you might use fentanyl, but in the post-operative period, morphine and ketamine are commonly used. Morphine is a long-acting opiate receptor drug, while ketamine blocks the excitatory neurotransmitters. All right. Ketamine will also target GABA and opiate receptors to some extent, but really what it is that ketamine reduces how excitable the postsynaptic cell is. Inhalational anesthetics usually include halothane and isoflurane. They hyperpolarize the resting membrane and make it more difficult to fire an action potential because you have increased requirement for depolarization to reach the threshold. Epilepsy is an umbrella term. So now we're getting into, so notice I'm talking about channels a lot more now, and we're going to wrap up a few conditions that involve the channels. Epilepsy we're going to talk about in detail later. You can pause and read this slide if you want to, but we're not going to talk about it here. The main thing I want to point out is imbalances in channels cause imbalances in excitability, and that can lead to epilepsy. In episodic ataxia type 1, you have defects in a voltage-gated potassium channel, which causes, these brief episodes of sudden, like ataxia, which is imbalance, loss of voluntary motor movements. In the type 2 version, it's way more severe, and you have cerebellar symptoms, and it's calcium associated, calcium channel mutation associated. And those symptoms can include vertigo, nausea, intense headaches. In spinocerebellar ataxia, you have trinucleotide repeats. That's why I put that in here. Spinocerebellar ataxia type 6, it's a result of trinucleotide repeats resulting in polyglutamine expansion. So keep it simple and not start a molecular bio lecture. You have a bunch of extra glutamine on the calcium channels that makes them defective. All right, you get the DNA expands in a way that it's not meant to, and it encodes for a lot of glutamines, and all those extra glutamines are negatively charged and they interfere with the positively charged. Glutamine is negatively charged, positively charged, and that interferes with the function of the channel. All right, it causes this sort of strain. They're just in the way, and the channel can't work well, and that makes the channels defective, and that causes breakdown of the cerebellar Purkinje cells, resulting in ataxia. Some of the other calcium channelopathies include familial hemiplegic migraine type 1, which is associated with very intense migraines that last for days, and that's associated with mutations in a voltage-gated calcium gene, calcium channel gene. And sinoatrial node dysfunction and deafness syndrome is caused by a mutation in a voltage-gated calcium channel expressed in both the heart muscles and the cochlear hair cells. Last but not least, cannabinoids, everyone's favorite drug. So the cannabinoid protein receptor 1 is a metabotropic protein receptor that is enriched in the substantia nigra and the caudes putamen of those who abuse drugs. So this receptor happens to be enriched in those who abuse drugs, so it may or may not make them more predisposed to abusing cannabis or other drugs as well. Perception is altered. So the way you see the world is changed because these receptors are present in the neocortex. Psychomotor control is decreased because, the basal ganglia, which coordinate your movement, and the cerebellum, which fine-tune coordinates movement. Basal ganglia are like a motor command station that make the general movements, and the cerebellum sort of fine-tunes the movements. And then, so that's why marijuana decreases your reflexes and your psychomotor abilities. So anyone who says I can drive better when I'm high is full of shit. And the presence of the receptors in the hypothalamus stimulates appetite, and that's why we can use it to treat lack of appetite, particularly in cancer patients. That's usually where we see it used. Presence of these receptors in the hippocampus leads to short-term memory loss, as hippocampus is the site of new memory formation. So not to call anyone out, but if you're a medical student and you smoke to relax on the weekends, you're not doing yourself any favors because you're impairing your ability to form new memories. And in medical school, every day is at least 2 hours lecture worth of new information. All right. So that is all the things cannabis does, and it's from a metabotropic protein receptor that is the target. All right. Thanks for listening. Have a good one.